All right, folks, if you're watching the YouTube feed, we're just getting ready to go live in front of our live audience on Zoom, and just have to get the streaming. So you're behind the stage with our esteemed panel right now, and we'll be going live in about 15 seconds and starting the show. All right, here we go. Have fun, everyone. Okay. And just remember, Sherry, that Aanchal's on Central Time, so maybe there's some confusion there. I don't know.
Taking care of it.
Greetings, everyone. This is Eric Glazer, and welcome to our live recording of Bright Spots in Healthcare, produced by Shared Purpose Connect. Each episode, we bring together leaders to not only inform you, our audience, but also unearth bright spots, successes at health plans, health providers, and other healthcare-related organizations around the country. Our goal is to identify as many bright spots as possible so that you can determine if these ideas can be applicable at your organization. We believe this approach of finding a bright spot and cloning it is the most effective strategy to improving healthcare in our lifetime. If you have not already, I encourage you to subscribe to the Bright Spots in Healthcare podcast. You get every one of our webinar recordings, every one of the interviews I have with executives around the industry automatically dropped onto your tablet or device. You can subscribe to Bright Spots in Healthcare by just typing in Bright Spots or the name Eric Glazer into any podcast app that you use, that you prefer, Spotify, Apple, et cetera, you'll find us there. So appreciate it in advance. Get on there and subscribe. We are going to, in the interest of time, and as we typically do, bypass formal introductions of our esteemed panel, our esteemed roundtable guests, as you see them in front of you today, if you're watching live via Zoom. We're going to put a link into our chat so you can get a sense of their incredible experience and all the expertise you're about to benefit from as we get going with our conversation. Today's episode is brought to you by our friends at Icario. If you do not know who Icario is, they provide a health action platform that unites pioneering technology, data science, and behavioral insights to connect everyone better in health. You could check them out at icariohealth.com. I'll spell that for you, ICARIO health.com. I think they're the perfect expert to be joining us for our topic today. Our topic is redetermination strategies to maximize Medicaid reimbursement. This is all going to be about building trust and connecting with a hard-to-reach audience. And I like saying about these guys, and these are my words, not sanctioned by their marketing department, but I really do truly believe that they're one of the unicorns in healthcare, because they're actually taking, combining innovation and technology with pragmatic, what I call non-healthcare related marketing to drive better healthcare outcomes for all the people that you take care of or insure. I'll tell you a little bit more about what I mean regarding pragmatic non-healthcare thinking later on in the show. So let's get started, and I'd like to talk about strategy to start things off and level set a bit around strategies or best practices that plans should have in place in anticipation of redetermination. So to do that, I'm going to bring in Errol, Pierre. He's the Senior Vice President of State Programs at Healthfirst, New York's largest not-for-profit health insurer. And I'm also going to bring in Marty, Janssen. He's the Senior Program Director at Colorado Access. They're a community-focused health plan that's been serving Coloradians for 25 years. So I'll start with you, Errol. What strategies or best practices are you putting in place in New York in anticipation of redetermination?
Sure. Thanks for the question, Eric, and thanks for having us on the show. I think the misnomer for many plans is that redetermination is either the sales job or the operations call center job, but we really at Healthfirst think of it as everyone's job. So we have a cross-functional approach where multiple departments are thinking about what redetermination will look like and how it's going to feel, and that everyone has a play to part. So definitely a cross-functional approach. And then we look at the member from a 360 lens. So all the different touch points that can happen, any touch point can become a point of where you can actually help someone recertify and stay with the plan. So that 360 lens is making the most out of every touch point you have, regardless of where it comes from. And I think the last big piece is really having a focused strategy around our community-based organizations. And especially for us, it's our physicians. If our physicians are educated on the process and know the rigmarole of Medicaid and how it works, we actually think that's an important investment to make. It's going to translate to the providers. An educated provider makes an educated member.
So cross-functional 360 lens where every touch point could be an opportunity, and then starting with physicians, educating them, educated provider is an educated member. Just a quick follow-up on the 360 lens. So could you give us a couple of examples of touch points that maybe we wouldn't normally think of as opportunities around redetermination or enrollment, where you guys actually have that touch point capable of grabbing that member information and going into that sort of educational process?
Absolutely. So obviously, quality teams are consistently thinking about HEDIS and QAR measures, and they're reaching out to members for them to get a colonoscopy or a new member visit. Well, if we have that member on the phone, or we do reach them through a text message or that letter, and we realize that there's an opportunity for them to recertify, we don't lose that channel. That while we're on the phone with them, while we're connected to them, if the next best action is recertification, we actually leverage that excuse to talk to them, to talk about other things that's very important to them. So that's just an example, versus being very siloed and saying, I only can talk about quality right now because this is my quality outreach. So even though the member's about to disenroll next month, that's someone else's problem to reach out to that member. We say, let's take advantage of the call right then and there.
Right. And so to really be effective there, you have to have a centralized platform, and then you also have to have the training cult. And you mentioned that it's a culture, right?
Absolutely.
What about you, Marty? What are some of the things you're putting in place in Colorado at Colorado Access?
Well, I would say, a lot of what Errol talked about is exactly what we are doing too, in terms of the cross-functional, the 360 lens. One thing that we, maybe when he's talking about touch points, I would say is really understanding your region that you're serving on a very granular level as possible. We really learned that during COVID to cross down to the neighborhood level, the census tract level, social demographics, social determinants of health data that we have, cross that with our registries such as diabetes and COPD and those things, and really get to understand where your most at-risk folks are, and who within those communities are they interacting with on a very trusted level, because that's just so important. So it really is, taking those things that Errol talked about and driving them down to a, as granular a level as possible within your region to get to understand the communities within your region and all those folks who impact your members within those communities.
Of course. Right. Just a reminder, folks, a quick PSA. If you want to ask our experts questions throughout the recording today, basically help me co-moderate. There's a Q&A module there in the bottom of your Zoom interface. You probably know that by now. And you could certainly ask questions, and I'll bring them into the conversation as the conversation flows. I want to get into some, maybe not technical talk, but we have a unique perspective today. We have Dr. Andrey Ostrovsky. He is the former U.S. Medicaid Chief Medical Officer, and he's presently the managing partner at Social Innovation Ventures. So Andrey, how will the Biden-Harris administration's American Rescue Plan impact health plans' approach to enrollment?
Well, I mean, that's a bit of old news, but I'm happy to rehash it. I think that the plan had some good provisions. Some provisions, unfortunately, weren't included. Probably the most notable one that the law kicked off and now the regs have really put into practice is the enrollment and maintained eligibility in the postpartum period. The American Rescue Plan law allowed for, at the state option, for states to choose whether or not they want to extend postpartum coverage to moms for an entire year after they've delivered their kiddo. This is very significant because if you look at research that was done by some of our colleagues over at ASPE, they did research last year and they looked at a comparison of enrollment in Medicaid prior to and then during the public health emergency. And what they found was that women that had Medicaid eligibility, they found that the churn off of insurance was as high, actually higher than 1 out of every 2 women. Whereas if you look at women that are commercially insured in that 6-month period after they deliver a kiddo, the churn is much lower. It's about 1 in 3. It's still unacceptably high, but there is a stark discrepancy there. And independent of insurance status, there were significantly higher churn rates or loss of insurance coverage for women of color compared to white women. So the American Rescue Plan, for the states that chose to pursue it, creates a wonderful way to reduce that churn. And from a financial perspective, as often obviously is the case, and unfortunately, but we still have to be aware of the financial implications. If you look at 12-month Medicaid coverage and you consider what that looks like in terms of monthly cost per member, for those folks that have a full 12-month continuous coverage of Medicaid, the average cost was around $371 a month. For folks who only have continuous coverage for 6 months, that cost bumps up from $371 to $583 per month. If folks only have insurance through Medicaid for 3 months continually, that cost bumps up to $799 a month. We're talking about a 3x increase in costs just by virtue of continuous eligibility. And so some of the provisions of the American Rescue Plan have eliminated some of the churn root causes, but there's actually an active proposed rule from CMCS, which I'm happy to dig into greater detail, that has some really fantastic recommendations and provisions that will further reduce the likelihood of churn as the public health emergency winds down and as more of the enrollment and eligibility processes rev up.
And what if the plan is in a, and this is an audience question, by the way, so I don't know.
Sure.
What if the plan is in a managed Medicaid state? Is there something they could be doing in support of redetermination?
So what I just described is independent of whether the state has insurance carriers administering the Medicaid program or not. I think some of our colleagues that actually work at the insurance carriers can speak to this directly. I mean, Errol, I'd love to get your perspective, but in my experience and interacting with colleagues at plans, and then also investing in vendors that sell into plans, there's a ton that plans can do. And I think the way Errol's phrasing it is exactly right. It's not any one entity's responsibility. It's everyone's responsibility, both from a financial perspective, fiduciary responsibility perspective, and frankly, an ethical and health equity perspective, all the way from the state Medicaid program to the carriers, to the providers, to the vendors facilitating things, to the community-based organizations and primary care providers. The trick is, what are the incentive structures to allow for practice transformation to happen when, let's say, a busy primary care provider is already kind of swamped? What else are they going to do in a limited number of hours a day to help with enrollment? And we could talk about, there's some research that's emerging, I'm happy to share, that can create some additional funding to support primary care and community-based organizations to do things like enrollment engagement, but also coordination, navigation, and addressing social determinants of health.
And I want to jump into communication and trust right now, or just in a moment. There's a couple of other tactical questions I'm going to bring back Errol and Marty into that Andrey teed up very nicely. So I want to go back to some very quick, when we're talking about those 360 and the touch points, Errol. Courtney asks, our biggest barrier is identifying an accurate recent date, a recert date. How do you accurately ID that renewal date?
Yeah, it's a great question. So I happen to be in New York, which is a managed Medicaid state. So we do work with our plan managers at the state, consistently trying to clean our data to say we either have multiple recert dates for the same member, or we don't have any dates, and that's a constant back and forth with the state to try to get the right data. Where there are instances where we don't have a restart date, what we then do, which is our best guess, is do 12 months from the enrollment date, which is anniversary. Not necessarily the best data, but at least it's something that is there if it's blank. One thing that we have noticed too is as a family unit, this is specific to New York, adds more folks to Medicaid or to Child Health Plus, the CHIP program, it can also change restart dates. So for example, Eric, you enrolled in February, but then maybe someone in your household also enrolled in Medicare in April. Sometimes the managed Medicaid organization will consolidate the dates so everyone renews in April. So we also try to do it by household versus by individual, so that we're calling the entire household as opposed to calling 4 people in the household individually.
Marty, how do you approach that ambiguous or lack of restart date?
Well, much in the same way. I mean, we go by the best data that we can at the time, and often that is a year from the last known date. Now we have basically a 3-month window of time in Colorado from the time we first notify somebody that they're coming up for re-eligibility to the time that they would be dropped if they didn't either meet criteria or respond in the way that they should respond. So during that time, as a health plan, we have a fair period of time to outreach to folks and to let them know that there are certain things that they need to do in order to continue their Medicaid eligibility, some of which is new. I mean, in Colorado, there are some forms that need to be signed and returned that over the, in the past haven't needed to be, in terms of, in the past, if you didn't have any changes to your situation, you didn't have to respond in Colorado directly. Now you do. So you have to sign a form and say, I don't have any changes in my particular situation. If you don't do that, you will be dropped from Medicaid for that. So, that's along with the end of the public health emergency, that's another wrinkle to this that's going to make it, I think, really difficult for some folks. But with that longer period of time to outreach folks, it does give us the opportunity to have the conversations we need to have with people during that window to get everything accomplished that they need to, if we have their contact information and if they respond to us. I mean, those are some big ifs.
Right. So let's talk about response right now. It's a good segue. Communication trust, obviously key and a big theme, certainly of this show for a while now. I want to outline some specific bright spots tactics that organizations are using that are working for all of you, and maybe break down why they're so effective. So I'm going to start by bringing in Aanchal Falken. She's the Vice President of Strategy at Icario. So Aanchal, you touch a lot of different clients. Maybe talk a little bit about how some of them are doing a better job than most in building a productive partnership with each member one by one.
Yeah, absolutely. And Eric, I'll say, Errol, some of the things you outlined hit the nail on the head perfectly, as we're partnering with several clients that are in multiple states, navigating the multi-state difference, but then doing it at a national level. We're seeing the cross-functional teams that are pulling that together, coming with a strong approach. So where we're helping them is make that plan. Like, what do you know about your current membership? Who are they? What are those restart dates if you have them? If you don't have contact information, how do we go shore that up as part of the planning phase? And then the how to reach them is actually, no different than other programs where with several of our health plan clients, it's, knowing how someone likes to be reached. It's not one channel. A lot of our research and programs in that quality health action space, Errol, is just that. It's a mix of channels. It's a mix of languages, right? It's not, and that's table stakes. I'll say, to be able to reach folks in the way they want to be. And some research we did in April on Medicaid and the topic of redetermination, pulling Medicaid members pulled out. Email was a big preferred channel because there's a lot of information, right? It's not just click a button and I'm signed up again. We know it's so variable state by state. So email popped to the top. paper mail, interestingly, did too. And you look deeper, it's the older population skewing in Medicaid that might still prefer that. And so the segmenting is step one, and targeting was step two. And then that 360 approach of different ways is spot on how we've seen folks go from knowledge and awareness, like, oh, this is the thing to care about, to take the action, the next step, and having that served up right away, right? Here is the local resource to call, or here is the phone number and person to go to. So those are the ways we've seen driving outreach and awareness in other programs, no different in some ways. So
how do you go about understanding preferences? Because you can make some assumptions, but often, assumptions lead to failure. So how do you make really smart assumptions, or to what?
Yeah, it's a great question. I'd say we're lucky to have a ton of data behind us through a decade's worth of outreaching on health action programs, really focused on Medicaid and Medicare lives. So those channel preference behavior patterns, it's built into some exciting modeling that we do, and know who to go after first, what channels, and what mix of channels. I can't emphasize that enough. It's the mix of channels, not just one, and the sequence and order of it too. And it's not the same approach for every member. It's absolutely different. And so that kind of data science kind of fuels how we support, a national approach for some of our health plans, but varying down to the states. And that's been really helpful as to help support that.
So Eric, can I chime in there one quick second? I'm very familiar with Aanchal's work and Icario's work, which is fantastic. I think an underlying theme that's really important as a technology investor is actually not technology at all. It is trust, right? I'm a pediatrician. I'm now primary care pediatrician in the safety net setting. The thing that hooks the patients is, do they trust you? Whether it's you're a physician or a community health worker or whatever it is. And there's some pretty good literature that shows that if there is trust, you can get significant engagement. And the real magic here, which is what Aanchal and her team have been able to do and are working on, is, can you combine the trust of a human augmented by the technology? There's a study in JAMIA that demonstrated that a technology-enabled live community health worker can reduce hemoglobin A1C levels by 1.5 points. There's another study that's in peer review right now that showed with the Medicaid population that over 45% of folks with uncontrolled hypertension can actually get controlled blood pressure. This is a human trust-based intervention that technology certainly can assist with, but I think that trust piece is so important. We can't lose sight of that.
That's a good call out. Good call out.
Absolutely.
You mentioned Aanchal, some study you did with preferences to email and snail mail for Medicaid members. Is that something you did on your own in conjunction with someone? Has it been published?
Yeah, I was in conjunction with Harris poll from back in April. So something happy to pull out and share on the chat here, folks.
Awesome. Thank you. What about Errol? What about Healthfirst? Communication, trust. I'm sure we covered some of the things that you're doing. You got referenced a few times, but any other bright spot tactics that you want to bring up here that the audience hasn't heard yet?
Yeah, I think I'll have my comments be examples of what both speakers spoke about. So trust, I can't understate the importance of it. So we have what we call facilitated enrollers. They speak many different languages, probably 25 or more languages in our community. In New York City, you can tell there's so many different ethnic groups. They can facilitate enrollment in language. We hire from the communities that we serve. We actually have over 26 community offices that are Healthfirst branded, where members can walk into with letters that came from the state in English, and we can translate it for them in person and help them through it. So I totally agree with trust factor. On the preference piece, we do enable text messaging, email, phone calls, letters, and we try to capture that information during enrollment. Probably 20-25% will get some of that information, but for the vast majority, we'll have to get it after the fact, after they enroll. But we try to house that information internally and then honor it. And that, I think, leads into trust too. So if someone tells you, I want to speak through email, but then you call them, that erodes trust as well. So it's not just, yeah.
So you mentioned the language, the roster of language diversity that you have. Going back to your answer earlier about, everyone, no matter what the touch point, is always thinking about, is this an opportunity to enroll, or when it comes up, help folks clarify or declare eligibility for coverage. How do you script them? Like, how are you enabling your how does some call center person who may not be a nurse, who's talking with someone about an administrative issue, maybe it's a billing issue, sees this opportunity, how do they know what to say?
Yeah, I'll give you a great example. So it's a spectrum. It's not a black or white answer. The example is this: our care managers, actually, if they're talking to a member who has an issue that they're being treated with, there's actually alerts in our care management system that will let the care manager know that this member is eligible for a sales intervention. That could be new enrollment, that could be a better product, maybe they're in the wrong product, that could be recertification. The nurse now has the opportunity to say, how comfortable am I talking to them about this? Maybe I've done a bunch of these, so I feel comfortable saying what I need to say, and there is a script. Or they're like, I'm going to only talk to them about this intervention I am right now, diabetes. But I will say, by the way, when I finish this call, I'm also going to route you to another area that can handle your enrollment, because everything I just talked to you about, I can only do it if you stay active. So we have to make sure you stay active. So as soon as this call ends, if you have time, you're going to get warm transferred to, the redetermination unit. Or if that's not good, give me a time where we can call you back, and we'll call you back. So that happens all the time, and our reps have the wherewithal to know whether they want to do it themselves, or they're like, this is kind of out of my purview, so I'll put a tickler in the system to make sure that it's done or it's transferred. That's kind of how we handle it.
And what about from a pop health strategy, raising it up a bit? I mean, to get to these, when you raise it up and you need to get to the folks and actually get them to engage, you need a population strategy. How are you doing? How are you working on it?
Yeah, we've done a ton of work with our enterprise analytics team on segmentation of our population, and the segmentation includes disease status, includes severity of the diseases, includes their neighborhoods, their languages, when they enrolled, who's their physician, all those types of things, to try to find characteristics and insights to know how they're going to behave. We haven't tested the model yet because redetermination hasn't started again, but we have a pretty good model to basically put them in segments to know who's the most likely to disenroll, who's the most likely to stay enrolled, who's going to do it themselves, who's going to call just for help. So they're going to do it themselves, but they just want to check and ask a couple questions. And so we have those buckets. That's how we're thinking about prioritization. Because, as a health plan, we're going to have 120,000 people re-enrolling every month whenever the public emergency period ends, and there's no way we could call every single person. So we're really thinking smart about, these are the people we have to approach first, and then don't just lean on call. Look at the preferences. Some will want a text message. During COVID, we had a lot of engagement through text messages about trying to find someone a site to get a test or to get a vaccine. And then there's the email preference, which Aanchal mentioned, which we do get traction through a lot of email as well.
Errol, just one quick follow-up from the audience. You mentioned CMS as a method for outreach. Does Healthfirst have to ask members for consent to be texted, or is consent presumed given the members' enrollment in the program?
Yeah, it's a great question. So the way we interpret the language in the rules are, if we get the enrollment, we're a state-based exchange in New York. When we get the enrollment from the state and there's a cell phone number there, we are considering that consent. The first message we send out, it absolutely says, press 1 to stop. So our first message might be, welcome to Healthfirst. Let's talk about your benefits. Let's do a welcome call, yada, yada, yada. And then at the end, press 1 to stop. So they do have the opportunity to disengage. Once they say no, then they're off the list. So we do make sure that we're very careful on who we text and how we text, because the last thing we want is for them to say stop. But that's how we take it.
Aanchal, and that story, that study that you just, by the way, thank you for posting that in the chat if folks want it. Was SMS evaluated as a preferred channel?
Sorry, Eric, is that, I missed the last part.
Was SMS evaluated as a preferred channel in that Harris study that you did?
It showed up as a channel. It wasn't the top two. And again, this goes back to, I'd say, knowing your members, the channel mix is going to be very different down to individuals. And so it was in this poll, email and paper mail popped up. But as you really know, right, Errol, like your Healthfirst membership, like knowing their dynamics down to what Marty said, right, beyond preferences, their SDOH, their zip code needs. Those are the factors that we pull in addition, that I say, combined with the preference. And it's different. Every individual has, and it's different by topic. So I know I keep saying it's different, but I think that's some of the secret ability to get someone to feel like they can hear it when they want to hear it and be ready for the information flow. So.
Okay, here's what I want to do next. We get a lot of these questions coming in from the audience are great. Thank you, everyone. I want to get into sort of what we could learn from other industries around reaching our Medicaid members. I want to talk about what Colorado Access is doing with the homeless, which you'll want to hear about. And then a very cool, I want to get Andrey's perspective on technology and startups. And we also want to cover a very cool program that Healthfirst is doing that you have not yet heard about. So we're going to do that all in the next half hour here. I want to, before we do all of that, give you a little bit more information about our friends at Icario. I cannot do this show each and every week without these great partners that we have that not only provide funding, of course, but they also provide incredible expertise in the topics that we want to cover for all of you. As I told you earlier, they're a health action company that deeply understands people by using behavioral research and data science to move people to take action for their better health. That's so important. I don't think as healthcare organizations, we do a good enough job with that. Icario's goal is to bring humanity back into the healthcare communications world by delivering a whole population solution, and they intelligently reach members through interventions by looking at driving low and moderately acute members to action with personalized outreach, and they could do this all at scale. And that's sort of what I meant by pragmatic and non-healthcare. They take a very, I'm going to call it Madison Avenue approach to understanding different consumers' values. And then they deliver specific words and distribute said words in a way that inspires change, behavioral change. So if you think about Coke or Apple or Target or PepsiCo, these companies drive us all as consumers to a certain behavior that they want, right, to purchase or consider purchasing their brands. And although their words and the advertising are different in healthcare, the principles are very much the same. So if you want to move the needle in your population health and value-based care and your redetermination efforts and meeting these Medicaid patients, speaking their language and using the words that are going to inspire them to interact and engage, I think you need to think differently about your consumer marketing. And I would suggest that you reach out to Icario to learn more about what they do and just pick their brain for ideas. They really do know how to personalize the healthcare experience and connect people to better health. And again, you can check them out at icariohealth.com. In the feedback form that you get in about 15 minutes, and you could tell me what we did right, what we did wrong. You could also request more information on an introduction to Icario. No pressure to buy anything. It's not a sales call. It's just a networking call. You want to learn a little bit more about what they know and what they do with the Medicaid population. Okay, so I talked about off industry. Aanchal, so let's talk about what everyone can learn from other industries to drive behavioral change and how we should be taking a more sophisticated approach to driving to a call to action.
Yeah, I mean, there's no shortage of examples that this group on the panel was very familiar with, right? You look at your choices every day. If you're going to a Target, if you're ordering on Amazon, they know what you last bought, they know what you need. And I think a challenge out of the gate for those things in healthcare is, do we have the right research date? Do we have the right contact information and data cleansing? And so some of those challenges we have partnered with our clients to overcome through better information, better contact dates and preferences. So, that is just foundational. And I'd say the ways we're taking the next step forward is when you look at the prompts, those consumer facing companies are able to nudge you to, like, hey, did you want to buy more? Are you going to run out of skim milk, or do you want this 2% off milk because it's a sale? They nudge you to something that you may not or not have been thinking of, or you typically buy and you need. And so that's a very simple example, but where we'll think about the complexity of Medicaid enrollment comes in, it's helping people know who to go to. Who is that CBO in your region? Who do you call? Who can you get connected to? Having that show up immediately as they raise their hand on a different topic they're calling in. Errol, I love your example as they're calling in or reaching out to get appointments scheduled. Hey, did you know you can go here, or where to go for information to get enrollment support? Those are the types of sophistication that we're infusing with the clients we're working with to support them wherever members are already coming in to interact. How can we remind you, hey, here's something you need, you probably didn't know, or maybe you know. How do we take you from that point into a support system to get you supported to stay enrolled, stay covered, all the steps thereafter, and build that trust in those small ways, as Andrey pointed out and Errol said too. That's how you start building trust. Here's a recommendation because I know who you are and what you need really well.
Right. And I imagine, Marty, when you think about trust, and it's probably the hardest subpopulation could be the homeless. How are you reaching those hard to reach people and the homeless in your population?
Well, and just to echo what everybody's been saying, there are about 180,000 words in these contracts that we operate for the state Medicaid agency, not a single one of which is the word trust. But we can't be successful with any of those other 180,000 words if we're not successful with the one. I mean, at the end of the day, people will only engage with things that they trust. And if you're vulnerable or down on your luck, your trust pool shrinks. So what you have to try to understand is, where are those contact points in people's lives where they'll be open to listening to and trusting the messages that we're delivering, and be open to really making a connection with us? And how do we best facilitate and grow our trusted presence in the landscape? Now, we've talked about a lot of these. In some cases, it might be digital programming, social media platforms, telehealth. But when you're talking about very vulnerable populations, such as folks who are unhoused, you need to find some way to interject a trusted personal connection into the conversation, or it will never go anywhere. Now, our medical enrollment services team, for example, has had success working with homeless shelters. We try to have a consistent on-site presence at least once weekly for a specialist on the team to meet with people at the shelters and see if they have Medicaid, or help them apply if they don't. And when we establish our consistent presence in an environment where vulnerable people feel at least a little safer, they're more apt to engage with us and let us help them. Due to COVID and lockdowns, we've had to try different ways at times to connect. One way we found success with is to have on-site staff at the shelter announce that we will be on the phone to have individual conversations with people and to help answer their questions and to see if they have coverage or need to apply. People will sign up at the shelter, again, a trusted place, and our staff will call the on-site office to talk to each individual in turn to see, if they already have Medicaid, if they do, to explain their benefits to them. If they don't, help them enroll help them enroll over the phone. Now, this was a productive forum during the lockdown. And one of the main reasons for this is that we weren't working from afar to connect with people. We were working through a trusted source to amplify our presence in a situation. We found that a lot of folks had Medicaid and didn't know it. We found that a lot of folks didn't understand certain benefits within their Medicaid package, such as dental. A lot of people didn't know that they had dental because that was something that switched a little while back in Colorado. So having those personal conversations, especially for the most vulnerable folks, You just can't overstate how important that is. And when you say personal conversations, that might not necessarily mean us leading the conversation. That may mean a trusted source bringing these folks into the conversation in a trusted and safe space. And as we expand upon this model, this trusted presence type of model, we're looking at building a cadre of cultural and community ambassadors who are armed with our messages and their presence in the community to help drive messaging about everything from vaccinations to how and where to apply for insurance and who to connect in order to help them find a doctor. This really is I think the next step in the evolution of community healthcare, understanding the best way to enhance your trusted presence in a space, and that the best way to do that isn't often with you in the lead. I mean, you need to let other people carry your message, I think, more often than not in these communities.
Right. So that's a perfect lead in, Errol, to Healthfirst. I mean, once you determine how to reach members, what program does Healthfirst have in place to sort of effectively communicate and educate the members? How does it work? And maybe what are some of the core components that you have effective?
Sure. Yeah, like I mentioned, we have a pretty substantial staff of folks that were hired from the community that speak multiple languages. I get really jazzed up about it because of how much they feel connected to the communities they serve and trying to focus on underrepresented populations. So I'll just give an example. During the pandemic, it was very scary to come out to an office, right, and say, I have to bring my paperwork, whether it's my visa, my passport, my W-2s to try to determine Medicaid eligibility to enroll. So we quickly used technology to be more human, using a Twilio technology platform that allowed our members to take pictures of their documents and text it to us. And so that alleviated the fact of them having to come out of their house. They could stay safe, quarantine in their home, and still do enrollment. We also activated video enrollment. So educating members on how to use Zoom, but even leveraging WeChat and WhatsApp and FaceTime to doing the enrollment over the phone. So while some populations said I could just do it myself, other populations just still wanted to see someone, even though it was virtual. And seeing someone that looked like them, that spoke their language, was again enriching some of the trust. We also have a website that physicians can use and community-based partners can use to do on-demand appointment scheduling. And the website has all of our enrollers by language, by location, by preferences. So if someone who speaks Urdu and is Muslim wants to enroll, they could actually find a Urdu-speaking Muslim enroller in there on the web. And they could either say, I'll see you in person, and I know the days you're going to be at certain sites, or I'll see you, we'll do it over the phone, or we'll do it through video. So that we're trying to get to a no wrong door possibility. So wherever you want to see someone, however you want to communicate with us, we just want to make sure we're not saying no. We really focus on that, on having our representatives connected to the community-based organizations. Many of our physician partners allow us to come on site to also engage with the members and their patients. And we also have this financial arrangement where the physicians are also inclined to feel like I need to keep these members active. If you're just on a fee-for-service chassis, they potentially aren't caring about whether the member disenrolls or not because another patient's going to walk through the door. We have a lot of value-based contracts. So the physician is encouraged and incentivized to keep the person active. So they're just another audience person that's talking to our members saying, make sure you stay active. What can I do? Because it's going to impact their contracts and the value that they're deriving from our arrangement with them. So again, it's like no wrong door. We literally are trying to find every part where someone can fall along the way and make sure that we have a gap for it to close.
Talk to me a little bit about the CBOs, because I know we talk a lot about them. Typically, they've been mentioned in passing a bit today. How much focus do you have on them? How big of a role are they in the No Round Door program?
Yeah, so think of it this way. We leverage a technology called NowPow. I think they've recently been purchased by Unite Us. That creates a synergy with our community-based organizations because they're getting referrals to their sites for things like food insecurity, Things like, the cost of formula was very expensive a couple of months ago. That was an issue. So if a member came to us and said, yeah, that's great, now I have Medicaid, but I still can't afford formulary for my baby, we could use NowPow to refer them to an agency that could find cost-effective methods to get them formulary. So that connection with the community-based organization is through osmosis, I guess, is a bi-directional relationship. So they're meeting patients, helping them with WIC, helping them with all these other services, and saying, by the way, here's a health plan that can help you. They're ingrained in everything we do, and vice versa. When we meet a member that has a social determinants of health need, we are trying to solve that through our NowPow directory, referring them to community-based organizations that we partner with. So it's sort of this holistic circle where the member feels wrapped around 360. The other thing is on our mobile app, they have access to NowPow as well. And so there is a stigma around telling someone that you're hungry. I mean, I wouldn't be comfortable telling someone that unless there's trust. So the fact that you can find all of these resources in the privacy of your own home through our mobile app, we also see that. We even see the searches on the mobile app when no one's around versus what they ask for when we're there to be totally different as well. So just giving the member dignity to search for what they need privately is also important.
So Errol mentioned a couple of sort of innovative tech companies, Twilio and NowPow, to name two. I'm going to bring back Andrey. Dr. Ostrovsky, are there, putting on your venture capital hat on now, are there startups or technology companies that are supporting plans on redetermination in other ways that we haven't heard of, or are they all doing this in-house, the health plans?
I think building on the theme of trust, the literature I referenced around the hemoglobin A1C reduction and the which is published in JAMA, and I tweeted out and put in the chat, and then their hypertension control study that's in flight or in peer review right now. That was a company called Inquisit Health, based out of New Jersey. They've got a pretty good footprint in the New Jersey and New York area, as well as some national contracts with larger payers. They're doing a wonderful job with their community health workers. There's a company out of California that's doing really interesting work that isn't focused on enrollment eligibility per se, but the end result is really the same. In the sense, it's a company called Pierre Team, and what they're focusing on is empowering safety net providers, predominantly federally qualified health centers, in helping them through their transformation from a pure fee-for-service environment to an environment where they can take financial risk. A really big challenge among those types of practices is their limited bandwidth to do things outside of their core competence around clinical practice and addressing SDOH needs once a member is physically there. The challenge is if a member or a beneficiary doesn't have a steady address, if a beneficiary has housing insecurity and or they have moderate or severe mental illness or substance use disorder, it's incredibly difficult to just get them in the doors in the first place. And so they've done a really nice job of combining human as well as technological outreach to folks and finding them and then getting them into the primary care setting. That same function ultimately results in their enrollment or re-enrollment in Medicaid, but that isn't the ends that they're going for necessarily. They're just trying to make sure that they're actually plugged into care. Another example, which I think may be a harbinger of some of the best-in-class activities around telehealth providers. I have an investment in a company called Monument. Their bread and butter telehealth solution focused on treating alcohol use disorder. The reason this is relevant to enrollment and eligibility is that if you look at how they perform on initiation and treatment and engagement and treatment quality measures relative to national averages based on HEDIS data is something like 10 to 14% in terms of folks that are diagnosed with alcohol use disorder actually initiating treatment. And the numbers are even worse in terms of sustained engagement in treatment. With Monument, their numbers are 4 times that in terms of their ability to initiate and continue to engage in treatment. And so I think there is a really interesting added benefit of some of these technology companies, specifically specialty and subspecialty telehealth companies, in that they are natively good exceptionally good at connecting with people through whatever routes it may be. Whereas traditional insurers, their bread and butter isn't necessarily connecting with people, right? Their bread and butter is not the Errols of the world, but the average insurer. Their bread and butter is basically being a fiscal agent. And so I think there's a lot of promise that telehealth holds, with the caveat that there is a ton of snake oil out there as well. And so partnering with solutions, especially through the lens of a state Medicaid program or Medicaid carrier, like, how do you decide which one is a good partner, which one is actually implementing evidence-based care, and then also will get you that engagement lift? That's a challenge. I'm happy to help folks to kind of suss that out. Ultimately, if there's published literature, studies, well-designed studies that show initiation and engagement rates, enrollment rates, that's kind of the pudding where we should be seeking our proof, so to speak.
Great. Thank you for that. That's great. So I'm going to shift a little bit to Medicaid members that maybe we miss, and how you enroll disenrolled members that sort of fall through the cracks. How are you doing that, Errol, at Healthfirst?
Yeah, it's a great question. So prior to the pandemic, it would take us about 2 weeks to find out all the members that disenrolled and then turn it into a chase list for people to now try to call them back and let them know that they disenrolled and try to bring them back to coverage. During the pandemic, what we developed is essentially the 24-hour turnaround time of the minute someone falls off, it becomes the chase list for pursuit. In New York State, the rule is you have 60 days after someone disenrolls to pursue them. On the 61st day, it becomes a cold call, so you're not allowed to do it. And so that turns into a list, and lists are as soon as you make a list, it becomes stale. So it's a dynamic list, meaning if the member disenrolled and for some strange reason they re-enrolled 3 days later, that list is dynamic where they'll fall off the list. So we're not calling back a member to say you need to re-enroll and they already did, and that causes confusion. So it's very dynamic. It stays live. It's also a list that's published to the physician. So if the physician has a panel, they can see their list of disenrolled members, but knowing that it's updated frequently so that they're not, again, calling members that have made a change. So what we did is to say, rather than having like a retention list and then a new business list, it's one list, and it's dynamic, and it sits in our Salesforce platform from a technology perspective, so that stays dynamic. People can see it, and the physician is also encouraged to see it as well, so that they see how their members drop off, and then they can act on it as quickly as possible.
Aanchal, anything to add there? Actually, before you do that, it just occurred to me. So we were talking prior to the show, and you were mentioning that you guys are in the process of publishing a very interesting case study around a Medicaid plan. Do you want to just tell everyone about that?
Yeah, absolutely. I'd say it answers your other question too, because I'd say, Errol, like that retention list and that turnaround is such an interesting option that some of our clients are doing. The one anomaly we've worked with is they're being so proactive. And one example to basically identify what might be an exchange plan option for that individual, so that if they're eligible for that, as they outreach, whether or not PHE is coming and the dates, they can outreach and say, hey, you can perhaps sign up in this alternative offering that we have. And the two customers we're seeing partnering with us on that, it's really proactive in trying to make sure someone doesn't lose coverage, which is just one way I'd say that making sure people don't lose out even before that even happens. So here's an alternative. Let's get you onto this, and here's the subsidies that are there, through 2025, as we've seen from the Inflation Reduction Act. Like you have some options there that let you keep coverage from a member perspective, should you have that option as a plan. to pursue that proactive moving of folks. But yeah, that's the example, Eric, I think, where it varies so much by state. So in I think a week or two, I'll have to ask Christy on our team, sharing the programs that we're helping a client specifically across 9 states, but at a national level, it varies on those state by state.
Well, let's do this. If folks want a copy of that study when it gets released, or maybe we get a pre-read or whatever, if you send it to me, I'll send it to the group if that's okay. If Christy says yes.
Is Christy on? Right.
Why don't
I'm sure she'll say yes. So yeah.
Why don't we put up a little poll? We'll see, Sherry, if you could throw that up. We'll grab that case study on redetermination. If you guys want us to send it to you, or when it comes out, let us know. Great stuff. So there's a bunch of questions from the audience. We still have a little bit of time. I did want to cover this important around the legislation and around sort of the Medicaid and the Children's Health Insurance Program and what that proposed rule is going to mean to our audience and our health plans. So Andrey, do you mind talking a little bit about that and what CHIP and in general, what that could mean to everyone's strategy as they think about enrollment and redetermination?
For sure. I think the implications of some of the proposed regulatory changes are applicable to the pediatric and non-pediatric populations. I want to make sure everyone is fully aware of that. So just for context, PHE right now is technically approved through July 15th, which means it's through, or rather October 15th. And it'll possibly get approved one more time, but unlikely after that. So I would say at the very latest, we're looking at November, December, January 15th is probably the end of these flexibilities and when the redetermination mechanisms really have to kick in. Having said that, CMCS recently proposed a rule, which I put the federal registrar link into the chat, and I tweeted it out as well. And what that rule proposes is super interesting, and it addresses from the beneficiary perspective a lot of the roadblocks that contribute to the ASPE study I referenced earlier around Medicaid churn and the cost implications and the morbidity and mortality implications. And some of the things that the rule proposed are really interesting. By interesting, I mean it's going to be a headache for certain states to implement them. But this is one of those rare cases where I think actually extra regulation imposed upon states will be a virtuous cycle, both for the state eventually, but also for the beneficiary. One of the things that's really interesting is that CMCS is proposing to align eligibility criteria for existing safety net programs like the Medicare Savings Program, MSP, or the Low Income Subsidy Program, LIS. And as long as someone triggers eligibility for those programs, they don't also have to redetermine and apply for Medicaid. They automatically become eligible, which is brilliant. Like, these folks are already pretty socioeconomically compromised, and they might as well be getting the automatically enrolled or re-enrolled. And I'm putting there's a AJMC article I wrote with a couple of my colleagues that provides an outline of all of these safety net programs, including the LIS program, the MSP program, SNAP, and some other programs that are really instrumental for the safety net. Another really interesting provision is making sure that there's alignment, requiring states to have alignment between MAGI and non-MAGI populations. In other words, MAGI's Medicaid beneficiary who meets eligibility criteria by virtue of their low income, non-MAGI folks on Social Security with disability status, foster care, so on and so forth. For MAGI populations, there's already requirements such that to a theme that some of our speakers spoke to, the individual can apply for eligibility in multiple ways. It could be written form, online, lots of convenient mechanisms, and not require an in-person interview. Some states have a very regressive requirement for an in-person interview. And so this rule actually eliminates that and merges non-MAGI and MAGI requirements into more of a streamlined, multi-form factor, non-in-person interview approach. And the final thing among many other proposed regulatory changes is timely determination. So I think I'm hearing from Marty and Errol, like some of the timeframes around determination and redetermination. Some states are projecting that it might take them an entire year to do their redetermination process. Some states like New Hampshire, they've kept those enrollment and eligibility processes humming, even though they haven't been reporting them per se. Some states like Louisiana, they stopped those processes. So the people that are newly hired to do enrollment and eligibility have never actually done enrollment and eligibility. It's going to be a huge learning curve for the new hired state staff. And so this new rule recommends or proposes that for a beneficiary that submits an application, they need to have enough time. So a floor of at least 15 days to submit required documentation, and that's open to comment. And then in terms of the timelines to make a timely redetermination decision, it could be as short as 30 days requirement imposed upon the health plans. So that's gonna kind of squeeze plans to, or states, I should say, and then in turn plans to make redetermination decisions really quickly. Technology can certainly help with that, but process optimization as well. So I encourage folks to comment. The comment is due November 7th, and I put the link to that in the chat.
It's great. Thank you. Couple of quick things. The links, I think we got them all there in the chat. We have our next show in 2 weeks, and we're covering Medicare. We're shifting gear to Medicare activation. If you want us to register you, sure, we'll put a quick poll up when we close out. We'll keep it up. You guys could just click yes. We'll register you for that live recording. I want to thank our friends at Icario and Aanchal, but the whole panel, Marty, Andrey, Errol, the work you did prior to the show, getting ready, and everything that you provided to the show live here. I really appreciate it. This was a great conversation. We're actually a minute early, which is like rare for me to let it go that long. So thank you all. This will mark the end of the show. We value your time, everyone in the audience, because this is your Bright Spots in Healthcare podcast. Thank you very much, everyone. We'll leave the poll open so you can register.